most of the problems stem from unrecognized anatomical differences, and it can account for most of all the airway management issues. So, needless to say, anatomy must be learned in detail. Airway management always begins with a thorough airway exam and history, which is a history and a physical exam. When you are managing the airway, it's important to be clear. What are your goals? Is it really just to improve oxygenation? Because you don't need to do anything invasive for that. Is it anesthesia for the intended procedure? You can leave that to us. That's part of our armamentarium of knowledge. However, there are situations, especially in the ICU, where critical care specialists must also learn how to intubate. Is the patient at risk? Is there a risk for aspiration? One of the main problems with trying to secure the airway is introducing more harm. Will you have a situation that will be out of control? Will it be a cannot intubate, cannot ventilate situation? So before you embark on actually trying to secure the airway, these are the questions that must pass through your head before you start. And do you have a team with you? I was inspired by Dr. Resurrection's opening remarks because he's right. We are in a new era of working as a team. There must be good communication, and there are specialties that we rely on to do what they're best at. Do you have a surgical team just in case you need an emergency airway? So one of the most important things is to recognize a difficult airway or something that will give you issues. So the lady on the left with the French braid, she may not look of issue to you, but actually among anesthetists, this is already red flag. Her small chin and her prominent overbite are signs that she is going to be difficult. The next one, sir, with the big mass in the neck, you might say, okay, definitely that's a difficult airway. But sometimes that airway, because it's anticipated, is actually easier than the one with the small chin, which may not have been recognized early on. You may say that the man with the beard on the right, why would that give you difficulty? He's obese. But however, even putting a mask on that patient is very difficult because there's a lot of leaks when you have a lot of facial hair. On top of that, where will my hands go? How will I hold his chin? So those are the issues that you must recognize early on. The lady on the bottom, she has scleroderma. She has limited mouth opening. You cannot insert anything beyond maybe 3 inches into her mouth. Also, she may have a limited range of motion around the neck area. So one of the tools we use for normal patients is, and actually all patients, we ask the residents and even us, we do a Malamparty Classification. And that just means you open your mouth, sitting up, and that we use this to assess the relationship of the floor of your mouth, the tongue, to the roof of your mouth, and then the structures around it. A class 1 would be an easy airway, and a class 4 will be a more difficult one. However, we don't just rely on that parameter. It's not sensitive or specific on its own. There are many other parameters we look for. So we look for neck circumference. How big is the diameter of your neck? Usually greater than 40 centimeters gives us an issue. It may limit neck mobility. Mouth opening is also an issue. Our ability to open your mouth will pose a problem when we're trying to stick a laryngoscope down your throat, right? Jaw protrusion and upper lip bite test. This is an easy test to do. If you cannot bite your upper lip, that means you will be a possible difficult airway. It might be a sign that the area inside your mouth is limited. You might have a high arched palate. I may not be able to stick a laryngoscope blade in the place that I need to. Malamparty score is just one among many. And then we measure your thyromental distance, sternomental distance, and definitely we take note if there's a beard. So the beard is actually important for us because sa beginning pa lang, when we place the face mask on you and we can't form a seal, it's already an issue. Body mass index, also greater than 28, gives us an issue. Lack of teeth and age over 55. Mouth opening actually is not such a very strong test on its own, but coupled with others, it will give us a combined sensitivity and specificity. Actually, thyromental distance is not that sensitive. It doesn't pick up. So just because you have a shortened thyromental distance or something that lies beyond the range, it doesn't pick up very well. However, it is very specific. And if you find that your thyromental distance is out of the range, definitely that will give us a very significant red flag. So our mnemonic is here. Boots. Stands for beard, obese, old, toothless, and snoring. So the things you have to ask before you embark as well is how risky is the actual procedure? Did the patient have a recent meal? Is she under acute trauma? Was there an acute trauma that occurred? Do they have reflux, gastric peptic ulcer disease? Are they undergoing narcotic therapy? Do they have chronic pain? Are they currently pregnant? Or have they just given birth? All of these give you a sign that there's decreased peristalsis. So the aspiration risk is high because there's a decreased gastric emptying time. Any meal will be delayed. So this is also something you have to take note of. So what do? We stick to our guns. We don't allow that procedures take place, like endotracheal intubation, if we can help it, beyond 2 hours. Earlier than 2 hours for clear liquids, breast milk is 4, formula is 6, cow's milk is 6, light meal is 6, and anything with a heavy protein and carbohydrate meal is 8 hours. So these are the minimum amount of time. No? Pero if you have a patient with acute trauma, this may be actually longer. So these are the images of a difficult airway. Anything that limits your neck mobility gives you a difficult airway. So the difficult airway algorithm was designed by the American Society of Anesthetists to when you recognize an anticipated airway that may be difficult. It's not meant to be a guide to be referred to in the midst of an airway crisis. You cannot use it when you are in the OR and find a difficult airway. It's too cumbersome to read, and it's actually a very, very lengthy algorithm. You have to study it very well. It's geared for anesthetists. So this is it. It's very long. You actually have to really study it for quite a while before you get it. No? It's something that you have to pour over the night before so that you have your plan in place. Another important advancement is point-of-care ultrasound. There are times when you recognize a difficult airway right away. One of the important things to also do is to identify the cricothyroid membrane. Now, this is something you might forget to do. Actually, ASA guidelines say that difficult airway requires this identification. 80% of anesthetists can identify a male cricothyroid membrane. However, only 20 to 30% of anesthetists can identify the cricothyroid membrane in a female. So you may want to ask your friends in the ENT or to do an ultrasound to identify this important structure in the difficult airway. And why do we do this? Because there are times in emergency situations when we have to do a cricothyroidotomy and we have no choice. So, like I said, as we went over, you have to ask yourself: is this going to be difficult? Is there an aspiration risk? Can the patients even take my induction agents? Is this an urgent situation? Must I secure the airway, or will it eventually become an emergent situation? Can I do it later, and will it be worse later? Is there equipment available, and is there expertise beside me or easily called that can help me if I am in trouble? When you're actually planning for an endotracheal intubation, another important aspect is how you're going to do it. Will you do it awake? Will you do the standard intubation sequence? Do you have to do a rapid sequence? And rapid sequence is done when the patient has a very, very high risk. However, you cannot do rapid sequence if your airway is deemed difficult. That becomes an unsafe situation. Is there equipment ready just in case? And is there rescue ventilation available? Can I ventilate? In the event that I cannot secure the airway, what will I do? So all your plans, A, B, C, D, they all have to be mapped out before you start. Are there advanced airway techniques that I know of? Or do I have a colleague that can help me with advanced airway techniques? Can I confirm if the tube is in the right place? Do I have advanced capnography, or do I have nothing of that sort in the center? So these are the things you have to consider, especially if you recognize that it's going to be a challenge. Another way to ensure success is also to ensure proper positioning. They found many studies have shown that sniffing position in the extended position is the best position. This will align all the axes, the oral axis, the laryngeal axis, and the pharyngeal axis will all be in line. So if you look at this picture, the last letter C has the alignment of all the axes. When you're in the ICU and you're assisting intubation, when they're in a panic, don't forget, put the patient in the sniffing extended position. So just simply placing a pillow under the patient's neck will help a great deal in ensuring success at the first time. This is a radiographic representation of how the axes are optimized in the sniffing extended position. And the sniffing extended position is shown here on the bottom left of your screen. So that block that you see there, that's the pillow. Just a note, if you are doing video laryngoscopy, it's a different ball game. So you have to put the patient in the supine neutral. So this is an exception to the sniffing position. Because the angulation of the blade of a video laryngoscope is such, you don't need to put them in the sniffing position. You can get away with doing it in the neutral position. Just a word on bag mask ventilation. I know there are a lot of practitioners out here that are tasked with ventilating before airway securing is done, before endotracheal intubation is done. These are the ways to ensure success. No? If you have a patient and you are asked to ventilate, the best position would be just to tilt the chin up. You put your hand on the forehead and you press down while you lift the chin with your fingers. This maneuver lifts the tongue away from the posterior pharynx. Another maneuver, when you have a more difficult airway, you don't seem to be getting anywhere with the chin lift, is the jaw thrust. This one directly lifts the hyoid bone and tongue away from the posterior pharyngeal wall by subluxating the mandible forward. And you do this by putting your fingers behind the mandible and thrusting forward. In the do process, do not forget the pre-oxygenation phase. So before you embark on endotracheal intubation or any intubation for that matter, whether it's with an LMA or the tube, do not forget to pre-oxygenate. This is the most important step because it increases your safe apnea time. There will be a point where you have to render the patient with not breathing. And so this step will allow you to have a longer time before desaturation occurs. Your first attempt should be the best, and you must recognize a difficult ventilation situation. Proceed with caution, communicate with the team, and recognize when you cannot intubate and cannot oxygenate. There may be devices there. You may have everything you have with you. However, an extra pair of hands is one of the most important. You must, if you are approaching a difficult airway, you must secure someone to help you out if you need. Even just a nurse, just to call somebody to have a knowledgeable pair of hands. Nurses are very important in this aspect because they can, it spells the difference between being successful and just falling apart because nobody can do something this difficult by themselves. Advanced airway specialist is nice to have, but as long as you have your wits about you and you have proper judgment, I know that you will be successful because you will not proceed if you are not sure. Like anything, to be good at anything we do, we must do a quality and safety training. And one of them is, this is instituted in the General Motors plan. This is a safety protocol: plan, do, check, and act. And airway management is nothing but a hyperbole of this. We just do this in a very high stress fashion. We plan, we do, we check, and we act. We cannot solve our problems with the same thinking we used to create them, said Albert Einstein. So I suggest in our airway management we do the same. A new and innovative approach to airway management is called the vortex approach. This one was invented by anesthetists in Australia, and they provide a simple, consistent template to prompt team recalls and application of technical background material in real time. This is what you use when you are in an airway management situation. It can be used because it relies on conceptual imprinting. This is what you do intra-op, and this is the way we decide to move forward. The vortex approach is applied when you are doing airway management, because the green area is the safe zone. This is the oxygenated zone. This is when before you put the patient to sleep. Now the blue zone is when you give your agents to put the patient to sleep. It's that point where you're rendering your patient unoxygenated. So at the end of your funnel, which is that circle in the middle, that's also the green zone. That's your goal. So before you get to that goal, however, you have the blue zone. And that is a precarious zone to be in. So your team will alert you when you've spent too much time in the blue zone. You're allowed 3 attempts to secure the airway. And if you're not, you must back up into the green zone. If you cannot back up into the green zone, then your team is asked to open the cricothyroid set. So this relies on recognizing a situation and recognizing the stability of the airway. It also puts the patient at first, and it requires a team effort. So this is the way we train for airway management now. We train as a team. So it will allow the operator to have a second sort of view on the situation. Most of the time when we have a dangerous airway and we find that we are not able to intubate, it becomes almost like a panic situation. So this time, we are allowed two attempts per lifeline. And the lifelines are LMA, face mask, and tube. If you cannot do it within 2 attempts, you are supposed to call for help, allocate a proceduralist, meaning call for a more advanced airway specialist, and then you prepare the kit at bedside. If you still are not able, you're still not able to intubate, then you must optimize the patient and do the rescue, which is cricothyroidotomy. Now, this doesn't happen on a regular basis. No, you need to have some training. So, our center does an annual airway management workshop. You can't practice on a live patient. You can practice only on a dummy, right? So we do this whole process, the vortex approach. We even practice with video Ringoscopy and fiber optic bronchoscopy in the proper forum, which is a 2-day workshop. This is what we did this in Medical City right before the lockdown. We also do simulation-based learning. We practice the vortex approach through simulation as well. This is in Baguio General Hospital in January, and that's the dummy. We used a whole situationer, and we act like it's really happening. So simulation-based is a very high fidelity way to learn things. So we even reenact the interview and even how we talk to the dummy. It's as if we talk to a real patient. So all of that was fine and dandy. However, COVID-19 hit in March, and this turned our airway management up on its end. And we were all of a sudden faced with a huge problem. Intubation was not only difficult, it was dangerous, and we had to limit our staff. We had to create a plan within a moment's notice. Siguro I created the plan within 2 days. We had to wear PPE at all times and learn how to work with that and avoid entering an infected person surroundings for much longer than. We didn't even want to stay there for a few minutes. We wanted to get in, put the tube in, get out. So we needed to create a plan. We had to follow, we all of a sudden had guidelines. So when I was doing my research, my sister is an ER doctor in Australia, and she gave me her guidelines. I looked at it. I also looked at the ASA. The UK came out with guidelines within the next day. And they recommended intubate only in a room with a negative pressure and greater than 12 air exchanges. Of course, I could not ask this from our management. That was too difficult to institute right away. But we did have a plan. We had to know and communicate that plan before entering the room. That was all we had. We had an algorithm and a cognitive aid to use in the room. We had to prepare all our equipment and drugs outside the room. We had to plan how to communicate before entering, aspirate all our medications, assign roles, talk to the team. We all had to do this because when we had our PPEs, we couldn't understand each other. We couldn't even hear each other. So this was done so that we could succeed only on the first attempt. We didn't want to have to repeat the attempts. So there are many adaptations we had to do. One of it was we couldn't pre-oxygenate. The way we adapted to that was as soon as we got the referral, we asked the nurses to place an N95 mask on the patient and put a nasal cannula. That was about the extent of our pre-oxygenation. Our video Ringoscopy was wrapped in plastic, and that's the one we used on first attempt. We didn't even attempt to do a regular laryngoscope blade. And if we had to do mask ventilation to do rescue breathing, it had to be a two-handed mask ventilation with a PE grip like this, like I show on the slide. Now, that is the safest way to do a mask ventilation. If you have to. If you don't have to, we don't do it either. When we couldn't intubate, and that was dreaded, but there were times we couldn't intubate, we had to rescue ventilate with an LMA. So instead of doing bag mask, we rescue ventilated with an LMA. So the most difficult adaptation, I think, was just to learn how to work with PPEs and not to rush the donning and the doffing, because we learned that a lot of the infections happen during the doffing. It was very costly for our hospital, also for us. We needed to protect ourselves in the beginning through our own means, because the hospital could not order enough PPEs right away. We also had to request for 3 trolleys, one dirty, one clean, one outside. We couldn't auscultate after intubation. We just had to look at chest rise before leaving to attach to the neck vent. Also, we were all of a sudden asked to do proning, and anesthesia was called to facilitate, because a lot of the attempts to prone the patient were dangerous and would result in extubation. So this was our setup. We couldn't follow this exactly because the 4 green circles are supposed to be operators. And we could only spare, because our team was only a team of 28 consultants and 12 residents, we had to save our manpower. So we had 2 inside and 1 outside. And this was always the setup. We planned this setup before we even entered. So we would show this to the nurses and the respiratory technicians. We had to have this setup so that we did not impede or cause any delay. Our problem, in addition to being dangerous, our patients were always on the obese side. They were almost always difficult. So we had to use a grading scale just to make sure that we had assessed the patient properly. And this Makocha score alerted us to have another senior anesthetist to prepare for. So Malamparty 3 or 4, if the patient had apnea, cervical spine mobility problems, mouth opening, whether the patient was in a coma, hypoxemia, or if the anesthetist was a newbie. So actually, it has a very low score. You already have to refer. So this was I just wanted to show you, this was what we brought in every time. This was on a laminated placard, and we would bring this with us because we had to memorize this sequence of steps on a short notice, and we did not want to rely on our memory. We were actually very scared in the beginning, so we would bring this visual aid with us all the time. Some adaptations that we learned from COVID-19 was that an intubation team was actually a very ideal situation. Our consultant would go on duty with the residents. We were about 28 and we were all voluntary. The hospital did not make us do it. The drapes versus box, we found the drapes actually more effective. In fact, the box was cumbersome and did not fit our obese patients. We had to learn alternate induction techniques because a lot of the patients were hemodynamically unstable. And in the beginning, we would experience crash. Like the patient would go into severe hypotension with propofol, so we switched to ketamine and midazolam. Sedation protocols were all of a sudden had to be designed on an instant because after we intubate, a few hours later, the patient would self-extubate. So we had to immediately put them under sedation after intubation. Otherwise, we had to repeat the process of intubating all over again. The nurses were also, we did not want to risk the nurses by them monitoring the patients all the time. So we had to install CCTV cameras. We also had a nursing shortage. So we did CCTV monitoring. And we would allow the nurses to opt the sedation protocol based on their observations. We also had to adapt to the protective equipment, which we had to wear at all times in the hospital. Even when we slept on duty, we were wearing our respirators. That's how scared we were. So So the plans for the future, the University of Florida has instituted, because of the pandemic, they now allow remote airway assessment. It consists of 3 photographs taken frontal, lateral, and one with mouth opening at a certain distance. So we are exploring this as a possible way to do some airway assessments. Not the only one, but maybe to help out our consultants who are, who are hesitant to do airway assessment on COVID patients. We also would like to explore a permanent airway response team. We noticed that we would be more successful if we had a plan and we identified patients who were in need of intubation or who are going to be in need of intubation in the future. So there are some parameters that we would list, like if the patient's RR was elevated, if the patient had a difficult airway profile already, the airway team would be alerted and we could do the proper preparations. Actually, an airway response team is part of many centers' regular staff. In Australia, they have an airway response team, and anyone can call the airway response team, even the patient's family, if they feel that the patient has difficulty breathing. An airway response team is coming to assess. Also, training for simulation is one of the most important things we learned through this experience, that it really helped us learn the protocol without causing damage to our trainees, without hurting the patients. We did seamless intubations under 10 minutes. And I would like to say all of our residents were COVID-free, even our consultants who were on the intubation team. They remained COVID negative for 8 months. Donning our Cougar PPEs. So it was early in the pandemic, we were relying on donations. And as Charles Darwin said, it is not the strongest or most intelligent species that survives, but the species that can adapt to change. I am nowhere near an airway specialist. I don't claim to be. But with the help of our team, I think we can adapt and have success in airway management. Thank you very much. That's the end of my talk. Thank you very much.
Okay, ladies and gentlemen, insightful, timely, and significant. We would like to welcome again all our participants. That's 3,700 participants nationwide and around the world. Welcome once again. So this is a wonderful afternoon. We move on to our quiz number 1. Let's see how much you remembered, okay? Now, quiz number 1. Pay attention to these reminders. Use your mobile phone to answer. Go to phone browser and type slido.com or scan the QR code flashed on the screen in order to go to slido.com. Enter the PIN code flashed on screen.